Hello and welcome to this session. Thank you for making time for this presentation. Today we are going to look at shock and with the following learning outcomes. We want you to be able to define what shock is, to be able to state signs and symptoms of shock, and those will be the general signs. Of course, the specific signs you'll be looking at them when you're looking at the 4 stages of shock. Okay, of which the 4 stages are abbreviated as ICPR. Lastly, we'll be able to describe the 4 major forms of shock, and they are abbreviated as HCDO. So, shock in general is a condition characterized by inadequate blood flow throughout the body. And when you have inadequate blood flow throughout the body, it results into impaired oxygen delivery and nutrient delivery to the different tissues and cells. And this condition is caused by a number of causes that normally forms partly the types of shock. So we have the sepsis, the excessive fluid loss. We have a weak heart as in the cardiogenic shock, allergic in the allergic shock, and the neuro damage, right? So we also have the impeded blood flow in the body. When you look at all these causes, they normally result in the body's ability being compromised to be able to maintain adequate blood pressure and circulation regardless of the type. Okay, before we proceed, we have to look at one key term here, the mean arterial pressure. So the mean arterial pressure is simply the average BP across a cardiac cycle. And we normally calculate it by multiplying the diastolic blood pressure by 2. Then you add to the systolic pressure and finally dividing the sum by 3. Right, so the normal range for the mean arterial blood pressure is between 70 to 100 millimeters of mercury. So for the body's main homeostasis to be maintained, the MAP has to be greater than 60 millimeters of mercury. Remember, the MAP is affected by the cardiac output and the total blood fluid in the body, and this is direct proportionality. So when it's increased, so the MAP you expect it to be a little bit elevated. All right, so supposing you have a blood pressure of 120/75, can you calculate the MAP for me? You simply take 120 plus twice 75, you get 120 plus 150, you divide it by 3. Okay, you have to get your MAP, which should be within 70 to 100 millimeters of mercury. Simply put, for us to have adequate perfusion, our MAP should be at least above 60 millimeters of mercury. All right, so we have the general signs of shock. All right, we can give you the 4 main one, which is number 1 is low blood pressure. We normally have a significant blood pressure, which becomes the hallmark sign of shock, especially the hypovolemic shock. So here you find that blood, now the vital body organs will not be able to receive adequate blood because of reduced blood. Okay, so the first sign is hypotension. Number 2, we have tachycardia and tachypnea. Okay, in that order. Now, for the body to compensate for the reduced output, it normally compensates by at least having an increased heart rate. So the heart rate increases in attempt to maintain organ perfusion. So this normally results in increased heart rate, and that's why tachycardia is our number 2. Number 3 is tachypnea, and in this case, remember the body has just the body is going to compensate also for reduced perfusion by increasing the breathing rate, tachypnea. Okay, so we're going to have rapid breathing rate because of reduced perfusion. Okay, so this year the body tries to increase oxygen intake in order to remove the carbon dioxide. Okay, we are also going to have impaired circulation or perfusion to the skin. And how does the skin respond by? The skin responds by, the feeling of coldness, being clammy on touch, and this is due to decreased or reduced peripheral perfusion. Also, we also have other organs affected, like if you have reduced perfusion to the brain, it will lead to altered mental status, so the patient is going to present with confusion, they are disoriented, they are restless, they are also showing some signs of anxiety and also decreased consciousness, all right? And sometimes in the extreme ends, they end up being unresponsive. So the muscles affected, so we have reduced supply of oxygen nutrient to those muscles. As a result, patient presents with weakness and fatigue and general malaise. So we also have the dry mucous membrane, the nausea and vomiting, weak or rapid pulse, hypothermia. And hypothermia is especially in prolonged and untreated shock. So the body pressure may drop, leading to hypothermia. All right, so those are the different general signs of shock. All right, okay, so guys, at this juncture we're going to be looking at now the 4 stages of shock, which you have said is abbreviated as ICPR. Alright, so the first I is for initial stage. This is the first stage of shock, guys. Okay, and here the body will attempt to recognize the insults and initiate response to try and maintain homeostasis. Generally, we have decreased cardiac output. What did you say decreased cardiac output is? Cardiac output is simply the amount of blood the heart pumps per minute. Okay, so we have decreased cardiac output, and this leads to impaired tissue perfusion because of decreased oxygen and nutrient delivery to those cells. So, how does the body adopt? We're going to have a shift from aerobic respiration to anaerobic metabolism. And what is the the byproduct of this shift? We have build up of lactic acid. Okay, we're having now the lactic acidosis. So the initial stage of shock is what we are trying to say. We have a condition characterized by hypoxia and anaerobic respiration, okay, leading to excessive lactic acidosis. Luckily, this stage, when intervened, is normally reversible. Okay, so we have some of the most common questions asked about the initial stage. Someone will ask, what happens as a result of the inadequate cellular ATP due to inadequate perfusion? So what happens? So there is failure of the sodium-potassium pump. So we have now sodium and water entering the cell, and this normally damages the cell. All right? Okay. What about what happens as a result of the switch to anaerobic metabolism? Okay, due to inadequate. Remember, we have inadequate perfusion, so we have the shift from aerobic to anaerobic. Okay, aerobic to anaerobic. There is now the release of the lactic acid, which is very toxic to cells. So as a result, we have now metabolic acidosis, which is, contributes to cellular dysfunction and impaired oxygen delivery. What about what's the impact of inadequate perfusion that leads to the shift to anaerobic? We normally have inadequate cellular ATP, so and breakdown of proteins for energy will result because we don't have the normal ATP that the cells are used to, which is more friendly to the cell. So the cell will have to turn to alternative sources of energy, and that is breakdown of proteins for energy, which results in accumulation of toxic waste products. Okay, so that is all about initial. In some cases, guys, the initial is normally covered under compensatory, all right? That's what some scholars will argue, but in this one we have tried to split it so that we have initial as the first one, then the compensation in the first case. Okay, so in the compensation it's also called the rescue stage. Okay, the rescue stage, we want to correct whatever is happening, guys, so we are going to increase the BP, okay, so that at least we improve the cardiac output, which will result in improved tissue perfusion. Okay, so these are different ways in which the body is going to respond. Okay, and the changes will affect the neural system, the endocrine system, and the biochemical response. So all of them, they try to maintain homeostasis by maintaining the cardiac output. Remember, decreased cardiac output is going to lead to a decreased MAP. So, and when this happens, the baroreceptors are found in two places. We have the carotid sinus and the aortic arc. So they'll be stimulated, so that will lead to now stimulation of the CNS. Okay, the sympathetic nervous stimulation that results into release of catecholamines, epinephrine and norepinephrine. And when these are led, they are potent vasoconstrictor. Okay, they will be increased vasoconstriction, and in the case when this happens, they're going to improve the contractility of the heart. Okay, and in the same process, the heart rate is also going to rise. Okay, so in the process, we are going to at least have some improved cardiac output. This process is still reversible, but in most cases you find that it's often missed out. So the first sign is usually confusion, okay, in most cases. What about the neural, of course, the neural response, okay? We also said that there's decreased arterial pressure, which is leading to a decreased hydrostatic pressure. So there will be now fluid shift from interstitial space to intravascular space. So as a result, the venous return will increase, and this will lead to increase now in cardiac output, improving the tissue perfusion. The third response is the endocrine response, okay, of the compensatory shock, okay, and this one we are going to talk majorly about the kidney, right? Remember, the decreased cardiac output is going to cause impaired renal perfusion. So this will be picked up by the renal, okay, and the juxtaglomerular apparatus, and this will activate the RAS system. So renin will be secreted from the juxtaglomerular apparatus, which is going to help in conversion of the angiotensinogen produced from the liver into angiotensin 1. Angiotensin 1 is a weak vasoconstrictor, okay? So we need the converting enzyme from the lungs to come in so that we can convert this angiotensin 1 into angiotensin 2, which is a potent vasoconstrictor. Okay, remember, it is the liver that is going to release the angiotensinogen. Okay, remember, if this stage of compensatory stage of the shock is not treated, it's likely going to proceed to progressive stage. Okay, so the angiotensinogen from the liver converted to angiotensin 1 by the renin from the kidney, the glomerular apparatus. Then angiotensin 1 converted to angiotensin 2 by converting enzyme from the lungs, alright? And this one is a potent vasoconstrictor, okay? It's going to cause constriction of the vascular smooth muscles, which is going to lead to increased afterload and resistance, right? Also, it's going to stimulate also the secretion of aldosterone secretion. This is by involving the adrenal cortex, which is going to produce the aldosterone from the zona glomerulosa. Okay, so the aldosterone will lead to increased sodium and water retention. In the process, there is increased preload. Okay, the volume of the blood, the volume return, and thus cardiac output at least is maintained to some level. Okay, Apart from the endocrine, okay, the neural, okay, we also have the GIT system responding to this decreased blood flow. Okay, remember decreased blood flow is going to impair perfusion, so the GIT will also affect it. So what the GIT does, it sends signals to either to stop working or work slowly. Okay, so this results in slow peristalsis, and thus our patient will be at risk of paralytic ileus. These are just frozen bowel. Okay, so bowel sound may be absent or severely super active. So that's how the GIT will respond. How about the integumentary system? How is it going to respond? Remember, decreased perfusion to the skin will make it cool, moist, and pale. So this will be different in early stages of septic shock, where in septic shock there will be extensive vasodilation. So the patient may be hot and flushed. Okay, remember, cool and clammy skin, especially starting the peripheral, will be the main presentation for the integumentary skin system. That is the skin, to be precise. Also, the respiratory system also is going to respond to this. So, lungs are richly supplied by blood. They are vascular organs. So, when you have decreased cardiac output, this will lead to portion of the lungs not being adequately perfused. So, we'll have decreased gas exchange, and the decreased ventilation will lead to increased respiratory cycles. So, someone will hyperventilate. So in the first place, the acid-base balance that is likely to result will be the respiratory alkalosis, right? Okay, so that marks the end of the compensatory stage. Remember, we started with the initial stage, then when we have gone to now to the compensatory, and now we're looking at the third one, which is progressive stage of shock. Okay, so you have decreased cutaneous blood flow, which leads to ischemia in the extremities, weak and absent pulses. So we can have also prolonged vasoconstriction, leading to decreased capillary blood flow, even leading to cellular hypoxia. So, in compensatory stage of shock, we are in fully anaerobic metabolism. So that means more and more lactic acid accumulation. Okay? Remember, in progressive stage, the compensatory mechanisms begin to fade. Okay, so now we have severe perfusion because we have decreased cardiac output. So here is when you're going to see the classic sign of shock, and this stage could progress to multiple organ failure or death, right? Because of what we are going to have. So in progressive, we are going to have retention of more acids. Remember, we are in fully anaerobic stage, so more and more lactic acidosis. The alveolar sites are going to become ischemic, and we'll be having hypoperfusion to the kidney, hypoperfusion to the liver, to the pancreas, and to the brain. So they're also going to present with some signs and symptoms associated with it. So at this stage, we have already said the body can no longer compensate. So we have significant drop in carbon significant reduction in cardiac output, and this will lead to hypoxic injury. There is also a fluid shift to the intravascular, right? Intravascular. So we are going to have now the massive edema, okay, because of the shift to the intravascular space. So the patient could have hypotension, okay, the heart rate may still try to compensate where you have tachycardia. The pulse may be thready, weak, and may not be palpable. The skin will be cold, synoptic, and molted. Respiration will be shallow. The patient could even be suffer from acute respiratory disease. The APGs will have decreased partial pressure of oxygen, decreased pH, and increased partial pressure of carbon dioxide. For the CNS, we are going to have decreased level of consciousness, so the pupils will have decreased. MAP will be less than 60, so the patient is going to be agitated, going to be restless, some are going to have slurred speech. In the kidney, because of the hypoperfusion of the kidney, we're going to have increased serum lactate levels and decreased urine output. How will the GUT, urinary tract respond? It's going to have loss of bicarbs because they will not be able to absorb the bicarbs, and this leads to increased tendency of GI bleeding because of loss of that protective shield of the bicarbs. Okay. Also, decreased perfusion of the liver is also going to affect a number of factors. First, the liver is involved in production of clotting factors. So, if perfusion is impaired, then it means that they are not able to produce these clotting factors. So, the patient is going to also present with also bleeding tendencies. Okay, next we also have going to the liver is also involved in the breakdown of these wastes. Okay, so if the liver is not working, you're going to have increased accumulation of ammonia, bilirubin, and this leads to a decreased level of consciousness for that case. We also have depletion of platelets, which also further makes the bleeding process worse, right, for that case. Okay, so from progressive, now we go to the irreversible stage. All right, irreversible stage. We are saying irreversible because it can't be reversed. Okay, it can also be referred to as refractory stage. That means unmanageable stage. So everything happening before is worse. Okay, everything bad is now worse than it was before. So we have severe tissue hypoxia with ischemia and necrosis. So we have build up of toxic metabolites like lactic acidosis in plenty. We have poor renal perfusion, renal failure, respiratory and cardiac failure, and sluggish blood flow. So the microclots, the tissue necrosis, the general condition just worsens for the worst. Okay, fine. For the BP, it will be less than 60. The heart will have muffled heart tones, and the brain presenting with stupor, coma, death, with multiple organ failure for that, right? For that case, right? So those are the 4 different types. Stages of shock, that is, you have ICPR, okay, initial, compensatory, progressive, and refractory stage. Okay, now let's look at the different types of shocks, and we have the DHCO. So we have 4 major types. Okay, we have the hypovolemic shock, which is caused by little blood volume, so the preload will be reduced in this case. Then you have the cardiogenic. Okay, cardiogenic, we have the compromise of myocardial performance, so we have decreased cardiac output in the long run. Okay, so problems could be due to cardiomyopathies, which are going to affect the contractility. Alright, then you have now the obstructive. So obstruction, so it's going to prevent the filling heart and ejecting into greater vessels. Okay, so blood flow is stopped, so it could maybe to be cardiac tamponade for that matter. And lastly, we have distributive. We have where we are going distributive shock, where we have excessive vasodilation that normally impair blood flow distribution, especially to vital or body organs. So referred to as the vasogenic shock, and it could be because of the neurons, neurological shock caused by damage to the nervous system, or septic shock caused by infections like the E. coli infection, or anaphylactic shock caused by allergic reactions for that case. Okay, so we have the hypovolemic shock. Okay, low blood volume is a major problem. So the low fluid in the intravascular space, that is what is going to contribute to this. Okay, Remember, the body can compensate for 15% of loss, okay? And 15% of 4 to 6 is what? Yeah, that it can compensate for that. But when you have between 15 to 30% loss, this will result in noticeable CNS activation, the sympathetic nervous stimulation. But when it is greater than 30, then compensation fails and organ dysfunction comes in, all right? So which type of patients are at risk for hypovolemic shock? Well, those who have who are suffered from BPH, postpartum hemorrhage, or trauma, okay, or trauma victims, or severe dehydration, those on nil oral, patients with clotting defects on chemo, postoperative. Severe is 40% volume loss. Okay, so elderly versus young, they will be having these smaller losses. Okay. What are the causes of hypovolemic shock? Well, we have both internal and external. So internal one could be maybe for the GI bleeding or the third spacing, ascites, bowel obstruction, peritonitis, or the burns where we have shift from the intravascular system, okay, to the interstitial. All right. Or the causes could even be external, where we have the burns, for example, or the hemorrhaging massive bleeding, okay? Okay. Then the sweating, the overdiuresis, diabetes insipidus, syndrome of inappropriate ADH, diarrhea, and vomiting. Okay. So what's the pathophysiology? Remember, we have a decrease in intravascular volume. Okay, so this decreased venous return to the right heart or the right ventricle will lead to decreased preload. Okay, this amount the ventricles are able to stretch at the end of the diastole. So decreased stroke volume and will result from decreased venous return. And stroke volume is simply the amount of blood the left vent pumps each beat. And for a normal, it's simply between 150 to 100 mils. We also have now, this will now lead to decreased cardiac output, okay, decreased cardiac output or decreased BP, which is going to now lead to decreased tissue perfusion. So you're going to have impaired cellular metabolism from decreased nutritional blood flow. So that leads to the shift from aerobic to anaerobic metabolism that comes up with those side effects. So we have different classes of hypovolemic shock, and it simply depends on the amount of volume one has lost. Okay, so it could be 15 or 15 to 30, 30 to 40, or over 40, and that gives us from class 1 to class 4. So for class 1, the loss is less than 15%, which is around estimated at 750 mils. So the body compensates to maintain the cardiac output. Patients are usually asymptomatic, but you find that the heart rate, BP, respiratory cycle, mental status, skin warm to touch, capillary refill, and then you have urinary output. They could be within the normal ranges. Then number 2, now we have the class 2, where the loss is between 15 to 30 is lost, and this amount will be it's estimated to be between 750 to 1500 mils. So decreased cardiac output normally activates the sympathetic nervous stimulation. So the RAS leads to vasoconstriction. Then you are going to have increased blood volume due to aldosterone and ADH secretion, leading to increased preload, and vital signs will be elevated. So the respiratory cycle, the heart rate, the capillary refill. So decreased, but urinary output will be decreased, the BP will be decreased, and the patient is going to present with mild anxiety, and the skin will be cold. For class 3, the loss is between 30 to 40%, and with the approximate volume being 1500 to 2000 mils. So compensation is not working, vital sign will be exaggerated, skin will be clammy. Lastly, we have class 4 where we have over 40%, so more than 2,000 meals is lost. Okay, so we have significantly abnormal to near death CNS coma in this case as part of the signs and symptoms. So how do you manage it? You manage by controlling the bleeding or the fluid loss. You maintain oxygenation, possibly on a mechanical ventilator. You insert 2 large bore IV cannulas like gauge 18, 16. You replace the volume and the fluids and the blood. It could be between the crystalloids and colloids. You also insert Foley catheter to monitor urine and to do telemetry monitoring and continue to monitor perfusion. So these patients are normally put in modified trended back. So you put the patient with the leg 45 degrees and then increased venous return will lead to increased cardiac output. You have to monitor lab values, okay, such as HB, HCT, arterial blood gases and electrolytes. We could use crystalloids. So this is a normosaline or lactate ringers. These are normally referred to as volume expanders. Okay, they add more fluids in the intravascular system. So this increases the preload, the stroke volume, and eventually the cardiac output. But the RN have to watch for fluid volume overload beside hemodynamically monitoring check for these elevated the CVPs and the PCYP. Okay, so fluid in the lungs you have to monitor so that you auscultate for the crackles. They diffuse through the capillary wall, so less of it remains in the intravascular spaces. Okay, so the ratio is usually 3 to 1, or the rule such that for every 1 ml of approximate blood loss, you have to add 3 ml of crystalloid solution is given. So if you have lost 500, then you are going to transfuse how much of the crystalloid fluids? 1500. Okay, 1500. For the colloids, examples include the albumin and the histostarch. Okay, these fluids consist of large molecules, okay, X proteins that cannot diffuse through the capillary wall, so that the fluid stays in the intravascular space for a longer time. The only disadvantage that most of them are proteins, so apart from being expensive, patient also can develop an anaphylactic reaction. So RN has to monitor for the fluid overload. For the blood products, we have whole blood, packed red blood cells, okay, fresh frozen clotting factors, and this one you have to monitor for reaction with these products. Platelets used for uncontrolled bleeding just to help with thrombocytopenia. Remember, whole blood is normally used for trauma, where 1 unit is equivalent to 50 cc. While the packed red blood cells, they are used for acute blood loss. So 1 unit is equivalent to 325 cc. While fresh frozen plasma, this is the liquid portion of the blood that is separated from the cells and the frozen and has clotting factors. 1 is equivalent to 100 to 150 cc. Lastly, we have the platelets. So we have the normal range 150 to 450 K, and you have to transfuse if it's less than 50. Okay, so let's look at some of the frequently asked questions on hypovolemic shock. Number 1. Which type of IV fluid will be used for fluid expansion in hypovolemic shock? Why? Yeah, the simple reason is normosaline, and it is isotonic and it will expand intravascular volume. Number 2 is, what is the reasoning behind telemetry monitoring for a patient in hypovolemic shock? Why do you do the telemetry monitoring? These patients are at high risk of developing cardiac arrhythmias. Okay? And what is the reason behind inserting a Foley catheter into a patient with hypovolemic shock? You just want, the kidneys the organs are will shut down, okay, soon. So the Foley catheter will help track urine output, hourly urine output. Minimum should be at least 30 mils per hour. Okay? What is the reason behind telemetry monitoring for a patient hypovolemic? You find that these patients are at high risk of developing cardiac arrhythmias. So when administering large volumes of fluids, you need to warm them, and the reason is to prevent hypothermia. Remember, it can alter clotting enzymes. So you have to keep the patients warm, but it should not be to the point of sweating. Okay. All right. So from hypovolemic shock, we go to cardiogenic shock. And cardiogenic shock is a life-threatening condition in which your heart suddenly cannot pump enough blood to meet your body needs. So this condition is most often caused by severe heart attack, because not everyone has a heart attack as a cardiogenic shock. So cardiogenic shock is very rare, and the causes include the cardiomyopathy, restricted cardiogenic shock, cardiac tamponade, and pneumothorax for that case. All right. So we do some testing for the cardiogenic shock. You could do the cardiac enzymes, EKG, CXR, CHO, BNM, and complete blood count. Right. So, how is it managed, the cardiogenic shock? You have to maximize oxygenation, insert catheter just to measure the urine output, and then correct underlying cardiac dysfunction. They should be cautious administration of nitrogen and do administration of loop diuretics. Remember, you can go even for positive inotropes like the G1 agonists, yeah, dobutamine. Okay. Then lastly, you have an intra-aortic balloon, the one that is used at least to control the bleeding. Next, we have the cardiac tamponade, and cardiac tamponade is when you have pressure on the heart by the fluid in the pericardial space. All right, the pericardial space has a fluid, so that's what will restrict it. So this could be because of blood, breast cancer, and pericarditis. All right. So here we normally have excessive fluid accumulation in the pericardial space, which leads to decreased filling of the cardiac chambers, and when this happens, there will be decreased cardiac output. Okay? Okay, another condition that can restrict contractions and relaxation of the heart is the tension pneumothorax, in which air enters the chest cavity and is prevented from escaping. So hole pushes and compacts the lungs and can cause mediastinal shift, right? Okay, it's there. So treatment of cardiogenic shock, you have to aim to improve cardiac output and increase contractility, preload and afterload. So the markers that the patient is improving could include if they are losing weight loss, if there is weight loss, if the capillary refill is less than 3 seconds, there are good pulses, urine output, maps are good, and there's decreased pedal edema. This warmth, BP and neuro checks are okay. Remember, decreased afterload in the cardiogenic shock, there is need for vasodilation, okay? Nitron and ACE inhibitors. While decreased preload in cardiogenic shock will have the diuretics, the furosemide, the fluid restrictions, and sodium diet, where we have less than 2 grams per day, okay? Okay. Next, we have the distributive shock. Distributive shock, we have a number and abbreviated as DSOP, right? DSOP, all right. So these are conditions where there is widespread dilatation of small arterioles, venules, or both. It could be due to neurogenic, that's spinal, or anaphylactic, where we have laryngoedema, massive vasodilation, and decreased BP and MAP. Then we have septic, where we're having severe infections like the E. coli, okay, the E. coli. Alright, so we could have vasogenic shock or the neurogenic shock. The neurogenic shock, we have sympathetic vasomotor activity, decreased muscle tone, which leads to vascular resistance. While vasogenic shock, we have septic shock and anaphylactic. So for the septic shock, we have vasodilator substances which are released from the bacteria, and anaphylactic is the histamine released from severe injections. This will result into distributive shock. All right. What about a neurogenic shock? And the cause is an injury to the spine. Okay, of course, level T5. So we have the loss of sympathetic nervous vascular tone, and this leads to vasodilation. So the no epinephrine, no epinephrine, no norepinephrine, and this leads to vasodilation. Normally have decreased beta 1 activation, which leads to activation and decreased decreased BP and heart rate. And neurogenic shock, as we had indicated, is a type of distributive shock. So the management is you manage using it fluids and vasoconstrictors. All right. So we have to maintain the APCs, maximize oxygen, ensure adequate volume, treat hypotension with vasopressors, and treat bradycardia with atropine, right? Okay. So this atropine is used to treat neurogenic shock. It's an anticholinergic drug, and it works by blocking acetylcholine, that is the parasympathetic nervous stimulation, so it raises the heart rate in the long run. It competitively blocks the effect of the SCH, including excessive acetylcholine, leading to opposing effects at the muscarinic cholinergic receptors, right? Okay. From there, I have anaphylactic shock, and this one is caused by allergens, so blood products, environment. So we have the histamine release of increased capillary permeability. This leads to edema and vasodilation and eventually circulatory collapse. You find anaphylactic shock assessment, you have to look at the respiratory distress. If it's not breathing, you have to start CPR. Okay, I think it will be popping up on how to perform CPR. Then avoid triggers like peanuts, the bee sting, milk, eggs, and if your child has an allergy, you have to notify the school, the church, and the neighborhood so that they can be assisted promptly. Okay? Okay, so remember to remove the offending substance, to establish the airway, administer epinephrine, administer diamphetamine, administer bronchodilators, and administer corticosteroids. Right? Okay. So the other form of distributive is septic shock, where we have bacteria gets access into the blood vessels, activates the white blood cells, white blood cells releases the cytokines leads to inflammation of the blood vessel, leading now to vasodilation. So it ends up affecting the brain, the lungs, the heart, the liver, and the kidneys. Okay, so you have to start by adequate antibiotics as early as possible. Resuscitate the patient from septic shock by using supportive measures to correct hypoxia, hypotension, and impaired tissue oxygenation. And then identify the source of infection and treat with microbial therapy and maintain adequate organ system function, right? Systemic response to infection. You find that in this infection, mortality is usually greater than 20. So severe sepsis is complicated by organ dysfunction, and sepsis resulting into hypertension, resulting into an adequate volume resuscitation. How to prevent this one? You can do the infection control, okay? Infection control, hand hygiene, standard precautions, okay? A link will be popping up on the isolation precaution and transmission-based precaution. So removal of catheter lines and catheters, postoperative Foley catheterization for more than days is associated with increased rate of UTI and 30-day mortality, okay? How do you recognize sepsis? You look at the temperature is greater than 38, the heart rate is greater than 90, respiratory cycles are greater than 20, white pieces are greater than 12,000, and saturation, of course, less than 90, and systolic blood pressure is less than 90. These have changes in level of consciousness and decreased urine output. We also have decreased lactic acid. Okay, so we have this campaign, the sepsis 6 intervention. You administer high flow of oxygen, you draw the blood cultures, you start IV resuscitation, initiate antibiotics, check for hemoglobin, lactate, and measure urine output hourly. Right? So the defining characteristics of a shock, we have to look at effects on the CNS, on the cardiovascular, on the pan, the renal, the skin, and the labs, okay, and the labs for that particular matter. Expected outcome for you to know if you are improving from shock, you look at the CNS, the skin, the adequate blood flow status in terms of the normal heart rate and the BP, and the urinary output, okay, which should be at least 30 cc per hour, or simply 0.5 mils per kg per hour, okay, for that case. Nursing intervention, you have to monitor the volume status, replace the volume as ordered, you monitor the vital signs and changes in physical appearance, keep the patients in a shock position, the Trendelenburg position. There's a link will be popping up on how to place a patient in a shock position. Okay, so all in all, you have to use the vasopressors like the epinephrine, have the alpha-1 agonist and the beta-1 agonist, and do not use until there is adequate fluid resuscitation. The reason why you should not give vasopressors without adequate fluid resuscitation is perfusion will otherwise become worse. Okay, so because the action clamps the vessels together, there being enough blood to reach, without there being enough blood to reach the body. So the others could assess for side effects like the tachycardia, the hypertension, the myocardial ischemia, and the tissue necrosis. Okay, so guys, that wraps the end of our presentation on shock. We have looked at the definition, the stages, and the 4 types of shock. Remember to access the free quizzes on the different topics pertaining our topic of study today.